And then we asked the men.
Hey.
And the men said, the first thing that came to their mind is, how much will it cost if we go to hospital? How much will it cost if we go to chemist? How much, all those analyses are coming into play. So what that means is that we need to engage men, but we also need to empower women as well. So we need to engage men so that they understand the importance of healthcare. We need to engage men so that they commit and invest in healthcare. But we also need to empower women so that they are also able to, when the child is sick, to support.
This is Development Now. And on Development Now, what we do is we highlight and showcase success stories. And where necessary, we also showcase the challenges of development organizations doing impactful work in Nigeria. We decided to start in Nigeria, break it out into other countries of Africa and then eventually the world. And so that way you're able to see what these organizations are doing. When I say organizations, I mean NGOs, CSOs, funders, okay, foundations that fund this wonderful project, okay. You're able to see what they do. You are able to identify with what they do. You're able to see yourself in it and, of course, support what they do. That's Development Now, and that's why we're here today. My name is Bumi Afolabi, also known as Mr. Speaker or Mr. Development. As always, I'm not alone. I've got Ugonna. I think today I should not be dramatic with our son. I'm trying, but
you can't help yourself. That's the thing. You can't.
I'm just going to let it out. Ugonna, Wajimogu.
Thank you, Bumi. Welcome to another exciting and engaging episode of Dev Now. I am Ugonna Uwachimogu, Bumi's partner in this. This is our way of making a difference in Nigeria and hopefully the rest of the world. Today's episode, I promise you, is exciting, it is engaging, and definitely will inspire you. So please stay tuned. Do not go anywhere. We have a special guest on our special couch who is going to tell us everything that we need to know about his organization, and I hope that you pay attention. You can learn something.
Okay. So like Ugonna said, and the amazing thing about this episode is since Dev Now kicked off, this is the first episode that's going to be centered on health.
Oh, it's true.
Wow.
Yeah.
On health for the first time.
It's the first time. Yeah. We started with environment. That was episode 1. We went to ICT. That's episode 2. For episode 3, for Action Aid, their mainstay is not health. I mean, the country director said it. Yeah. A lot of activism, the legal aspects, justice, gender, and then, of course, environment. Those are their main areas, right? And then, of course, we've had Citizens Gavel.
Yes.
Okay, that's a purely legal stuff.
If you like your legalese.
This is the first time we're going health. I'm really excited about health. Because if we're not healthy, we'll not even be here.
Yeah. So, there's this saying. I saw this somewhere on Instagram where it says, "You think you have 1,000 problems until you get really sick, and you realize you just have one big problem." Yeah. Yes. Because if you're not alive, those problems should not even exist. Yeah. So I'm very excited to talk about health because I think it's primarily what we need. I think it's the most important thing when we talk about we all have our different problems. We have our domestic issues, maybe financial issues, maybe business issues, but I feel we take our health for granted. We forget that the most important thing is to stay alive and be alive. And also not just being alive, but being healthy. We take for granted the fact that we can walk. We take for granted the fact that we can talk. I always tell people, sometimes visit a hospital and you might come out with a whole new perspective of life.
Yeah, true. So we have the honor and privilege, all right, of having on Dev Now to break the yoke of health. Because it's the first person from the health space, in development to grace Dev Now. All right, we have the country director of Engender Health here in the person of Dr. Kabiru Atta. You're welcome.
Thank you so much, Bumi, and thank you so much, Ugonna.
Yes,
pleasure to meet you.
Pleasure to meet you.
I'm happy to be on the show.
Yes.
I mean, like you rightly said, we all grew up with the idiom "health is wealth."
Yeah. Yes.
Everybody grew up with that,
and
so whoever coined it must have seen something, or have experienced something, and it just goes to show the fact that we need to invest in our healthcare.
Yeah.
And of course, Engender Health, because we're a leading global organization working in the sexual reproductive health and rights, and also for gender equality. We're in Nigeria, we've been around since 1985.
In Nigeria.
Since 1985.
Sorry, pause.
Just when Bumi turned 30.
Remember?
Yes.
I'm going to
I don't know.
I'm going to act like I didn't hear anything. Yeah, but you're going to come back to that. Sorry to take the wind off you, but for devnow viewers, you see that's one of the reasons why devnow was birthed. And gender health has been doing impactful work in Nigeria since
1985.
We shot this clip. I don't know which year you're saying it. We shot this clip in 2024. Someone who was born in 1985 should have how many children now?
Yeah.
Well, depending on how many person was having.
I mean, someone who was born in 1985
who say, I'm done having kids.
should be about 39 now.
Yeah, but that's 9 years. Yeah,
thereabouts.
I'm just showing off my math skills. That's the only math I know.
No, she does have math.
That's the only math I know. Once you introduce letters to numbers, you've lost
Find
me.
X.
No. I will go and bring my actual X.
Wow,
so,
1985.
1985, and really, when you look at health, it's really a state of really physical, emotional, mental well-being. You're looking to make sure people have the rights. When you say right to health, people should have access to good quality health care.
Yeah,
you understand, irrespective of fear or discrimination or stigma in Nigeria. And so what we've done really in gender health is to really focus around, like I mentioned, sexual reproductive health and rights. How do we make sure women have access to family planning services? How do we make sure communities are supportive of them? Men are supportive of them. Men are involved in the work we do.
In the process.
How are you ensuring that you're breaking down gender barriers, transforming gender norms, who could actually limit access to women and adolescent girls to actually access services as well. And then, looking at the whole concept of maternal and obstetric care, when a woman is pregnant, does she have access to high quality antenatal services? Does she have access to safe delivery from a skilled birth attendant? Does she have access to, for the child to be able to go through the full schedule of immunization coverage, which is has a big impact, on the healthcare for children as well. So we look at that whole gamut, and then we also recognize that Nigeria has something they call a youth bulge.
A what?
A youth bulge. So if you look
youth
at
bulge,
a bulge, like
elaborate.
A bulge. So like a bulge. I mean,
beer belly.
None of us have big belly. I have the biggest stomach. But like a youth bulge, if you look at the population pyramid, that stacks up in terms of the lower base, the age, and then as you go higher, in stacks of 10, you find out that when you look at the young population, in Nigeria between 10 to 35, you find out that it bulges out, which shows that you have a lot of young people in country, and how do you make sure these people are involved in the health sector planning, the health sector design, because they are the leaders of tomorrow. So in Engender Health, we also try to pursue meaningful youth participation, because how do we make sure that we are also considering their needs? They are actors, they are drivers, of the healthcare reforms we want to see in the country as well. So that's one of the work we've been doing in the last 85 years in Nigeria.
Wow. So how would you describe, or how would you rate the Nigerian healthcare system overall? How would you, if you were to put it on a number over 10, how would you what would you score Nigeria's healthcare?
So Nigeria healthcare system, we've made progress.
Oh God!
But we're not yet there.
We're not there yet.
Yes, because before I start, I have to acknowledge all the efforts of the government, development partners,
a lot of development partners
who are in the last, I will say since 2013, have made massive investments in country to see how we move the dial.
Have those investments taken root?
Yeah. So because if you look back maybe 12, 13 years ago, our maternal mortality rate was about 1,000 women per 100,000 birth. So it means for every 100,000 women that give birth, 1,000 will die, right? So in the last 12 to 14 years, we've dropped that to about 512.
That's like taking it halfway.
Yeah, it's like halfway. You understand? Now, we've not done it at the pace that we should have, looking at all the resources that we have. And that's why we still, when you talk about the ranking, right? We still contribute the highest burden of maternal mortality
in the world.
Globally, Nigeria. We used to be at par with India, but India has made much more progress in the last few years as well. And so there's still a lot of work to be done. The new government, has tried to put in place some new reforms, like the Nigeria Health Sector Reform Initiative, the sector-wide approach program of the new Minister of Health, to see how do they begin to bring everybody together through one plan, one implementation action, and one funding pot, and one source of data reporting.
Okay.
Fundamentally, when you look at Nigeria, I also tell people, you need to think of Nigeria as, and I love Nigeria, but when you program, you need to understand that because we operate a principle of federalism, it means that each state, like a country of its own.
Yeah.
So it means even where the president or the minister is trying to direct policy, each state has to adopt it.
So that means you still have to go to each state to advocate that they adopt the policy, and then they implement.
Are some states more difficult to navigate than other states?
So I won't say difficult. I will say priority, because
who doesn't want to prioritize health?
Yes, because we talk about the health agenda, but like we're talking about health, you also have education, you have agri, you have everybody competing for attention, right?
From the same government.
From the same government, yeah. So, but the issue is that how do we, as health sector actors, like devnow, with the brilliant work you are doing, how do you continue to raise the voice, conscientize people about the issues in the healthcare sector? How do you increase the salience of PHC? How do people see health as being important to them?
Yeah.
And how do we begin to look at health more as from an investment angle? In the last, historically, people looked at health from the medical perspective.
Yeah.
Like doctor, nurse, patient, hospital sector, right? But then there was some new discussion around the social aspect of health, which is now saying that health just goes beyond the individual, but it has an ecological system. So the determinant of how I will behave is determined a lot by not just myself, but the community I belong to, by my peers.
Yeah.
Is determined by the access I have to healthcare facilities.
Okay.
Is determined by the access, which is the facility structures.
Yeah.
Is determined by the policies that exist. All of these can propel me and determine whether I am health conscious or not. Let me give you a typical example.
Okay, please.
So let's imagine that I'm in Nigeria and I stay in Jabi.
Okay.
But I want to ride my bicycle to work every day. This is where I work.
Okay. Jabi to Central area.
Right?
That's for those who don't live in Abuja, that's like how many kilometers?
Let's say 15 kilometers or 20 kilometers.
Let's just say VI to Lekki.
Yes, exactly. VI to Lekki, yes. I want to ride my bicycle. I have the money to afford a bicycle.
Yeah.
But I think of the traffic, the cars going on the roads.
Yeah.
Everybody rushing to work. There's a high risk that I could get hit by a car.
True.
But if you go to countries like Denmark, they actually have bicycle paths that have been constructed
for you to
you to go where it's safe with enough barricades. So it means that if I'm in Denmark, I'll most likely, and I want to ride the bike, I'll most likely be encouraged because I know that I have more protection. I don't want to ride the bike and get an accident, right? Yeah. Because I want to be healthy, but I don't want to also land in the hospital where the healthcare system is also not giving me what I want as well.
Yeah.
So all of these, and I began to say that you can't look at health at the individual level. You need to look at health across the individual, the community, the structures, the systems, and the policies, and the law and the budget. And that's why in Engender Health, our theory of change is saying if you can empower the individual, empower the woman with the right knowledge, empower the adolescent girl with the right knowledge, you also need to work with the community to make sure that the men who are part of that community understand the need for the woman to go to the hospital. They understand the need to support her in the hospital, in the process, right? And we need to make sure that there's a facility that is able to receive the woman in a respectful way, provide a significant privacy and confidentiality to her, to be able to express her desire and fulfill her sexual reproductive health rights as well.
That is a lot of work. Now let's start trying to break it down. From what you've said, for DevNow viewers who are seeing you for the first time and hearing about Engender Health for the first time, they can almost deduce that you do a lot of work at the community.
Yes, across several layers.
Several
work at the community, at the policy level, because for your program to be effective, you need to work across all levels.
Okay.
And the strategy really is to underpin it with using data for decision making.
Okay.
So as you are getting information from the community level, how are you using that information to inform policy change up there? So for instance, now, if you take a map, Bauchi is if I remember correctly, is either has one of the largest landmass in Nigeria.
Okay.
Compared to Lagos State.
Lagos is the smallest.
Yeah.
Lagos is the smallest.
A lot of people don't know that.
So we have, so if you compare the contribution to maternal deaths across states, Lagos will probably be one of the highest. The southern states will be compared to the northern states, right? But you will find out that they may have the same equal number of primary healthcare facilities and secondary healthcare facilities. They don't have the same geographical landmass.
Yeah.
You could put Lagos State almost 10 times in Bauchi State.
True.
But they have the same number of facilities, right? So what does it tell you? Access to care. If you're in Lagos, you come out, you drive, you see a facility. If you're in Bauchi,
you have to drive miles.
You have to drive for longer distance, right? So we use this data from the community to now inform government to say you need to invest in more primary healthcare facilities. You need to invest in more ambulance services for your people. You understand here? So it means that in the work you do in the health sector, you are working across several layers. And then we're also saying, how do we begin to be, like I mentioned, see health as an investment? Most people typically, when you talk about, if this was an investment podcast, right? Where the topic was
talking investment and numbers.
Yes, and numbers, right? You might not find it, see a way to bring health into it. But you need to understand that when people save money and they put investments, typically we want to invest more to buy more produce.
Yeah.
If it's for a woman, who has a business, or like for DevNow, you're investing more in your business.
Yeah.
You want to buy land assets.
Yeah.
Right.
Yeah.
But investments really are supposed to do two things. They're supposed to help you grow your wealth.
Yeah.
And they're supposed to help you protect your investments.
True.
Now,
True.
The protection part comes to health, because if you are sick,
you can't do nothing.
Yes, I mean, for this podcast, if we were supposed to meet here at this time,
and
when I says, "Oh, I'm not feeling fine," right?
There goes this episode.
This investment is gone.
This investment is gone. Yeah.
So, and that brings the concept of health insurance. How do you invest in health insurance to protect you from future shocks? Because you are healthy now, but you will get sick in the future. The nature we don't know. Yeah. But I know I will get sick in the future. Yeah. I'm not going to say no, by the grace of God I won't get sick. No, I will get sick as long as I'm alive. Yeah. But how do I make sure that when I get sick, when my wife gets sick, or when my children get sick, or my mom gets sick, I am protected from the financial catastrophe that can occur if I don't have something as simple as health insurance?
They say it's for people who are in the middle class, which is nearly obliterated in Nigeria. They say you're one health scare away from being destitute.
Yeah, you truly are. You truly are. And it's really shocking how the level of awareness around health insurance, and that's one of the things Engender Health is working on. We're trying to see through the work we do besides the direct service delivery, where we provide access for women in health facilities, supporting capacity building, making sure their equipment's available through the investments from the donors that fund us. Yeah. We're also saying, how do we improve domestic resource mobilization, where citizens are contributing to the insurance pool, and allowing how more women and more girls have access to healthcare? Because if you give a woman, for instance, we want to support women in business, right? And she starts her business and is successful. If her child falls sick or gets ill and requires surgery, the bill alone can
wipe it off
can wipe
everything
that
she
investment.
saved.
Average surgery, maybe fracture, maybe 60,000 naira, right? If you have to pay 60,000 naira out of pocket for a woman in the rural area, it wipes out your entire produce, your entire business. But you have health insurance, which you pay 12,000 a year. Imagine when that bill comes, you pay nothing.
Yeah.
And it's not
Just
money,
wipes it off.
It just wipes it up as well. So increasingly we're beginning to see how do we key into the universal health coverage, which is really making sure more Nigerians have access to health through the health insurance pool as well. Yeah.
Okay, so health insurance. How is that playing out?
Yeah.
I'm going to try to shy away from some things that have happened in the past. Yeah. Regarding health insurance. But we all seated here, and a lot of devnow viewers know about how the whole health insurance thing has played out. And incidentally, yesterday I was speaking with someone who works in government, like a mid-level officer. And I was talking about health insurance because I was relating it to the gym. Because I have options.
As your health.
And the question she asked me was like, oh my God, can't I be one of your dependents? Because even when I go to the health center, and this is someone in the urban city in Abuja, so eventually I'm still going down to grassroots, you know, can't I be one of your dependents? Because I go to the hospital, and because of the way the health insurance is structured, it's not our business who was indicted. That's not our focus. Yeah. But because of the way it's structured, I need drugs for migraine. And they won't give me. They'll tell me it's not covered. And then if I want to pay out of pocket also, they won't accept it. So I have to go outside, go to a pharmacy to get it. So I just want you to describe more of your work in this area, because it's an area that is very touchy for Nigerians, you know, and there's already that lack of trust in the system. So maybe you want to speak more about your work in that area.
I think the trust is the key issue. And like you said, because of what has happened in the past, and that's why government and partners like us are working to see how do we rebuild trust within the system. In truth, when you start a health insurance scheme, it requires a pooling of resources. Because health insurance is more like an equity program where the people who are healthier and are paying, and people who are most likely to get ill are also in the same pool. So the idea is that people who are healthy may not go to the hospital as much as people who are prone to get ill. And that means the pool is able to sustain
itself.
Everybody. I might be contributing for 5 years. I might never go to the hospital.
True.
Right? But my pool, my funding is subsidizing
for somebody else.
For somebody else. And when you can get that to happen universally, like you see in several developed countries, then everybody can be covered. So now the challenge is that typically health insurance, until recently, did not have the structure to be able to effectively cover Nigeria. Like I said, I will come back to the issue of the federated nature of Nigeria. The health insurance was previously run by the National Health Insurance Scheme. Which was based in Abuja. With offices across the 36 states. But that does not give ownership to the states to be able to imbibe it and adopt it as their policy. And so, but in the last 12 years, following the approval of the National Health Act in 2014, just before former President Jonathan left the country, office. And then former President Buhari also started to implement it, the acts when he came on board. It now calls for decentralization, which means each state now have their own national health insurance agency. And then the government invested through something called the Basic Healthcare Provision Fund that gives 1% from the Consolidated Revenue Fund into a pot and is shared across the tiers of government to the states to enroll. Currently, I think I don't have the updated numbers, but I would say we have almost maybe 10 million Nigerians who are currently enrolled in that scheme. Now, but the challenge nationwide, yes, out of the 200 million.
I just wanted to say 10 million, 200 plus.
Yes. But the challenge is you need to get more people into the scheme, like me and you, who are paying, because that scheme is funded completely from the government coffers, right?
Yeah.
So, but if you can get more people from the private sector, more people from the NGO sector, more people in the rural areas, putting in, even if it's 1,000 naira every month. The system at the beginning will not be perfect, but what happens is the more people pull money, there's more resources available, and then because the money is not coming from government, it's coming from people's money, there's more public accountability, because people who are giving money from their hard-earned salary, when you go to just what you mentioned, when you go to the hospital and you say, I want this drug, you don't have it, you say, no, I have paid for health insurance, and then
I
you
must get it.
Yes, and it becomes the multiplier system. I remember when I was working in one time in Sokoto, and in one of the local governments, and I was talking with someone working in one of the local governments in Sokoto.
Yeah.
I won't mention.
Yeah.
And he said, our local government chairman is so nice. He has abolished tax for us. We don't have to pay tax from our salaries. Then I said, how can you then hold him accountable? Yes, because to you he is doing you a favor, but that system takes away your power to hold him to account. And that's why you see countries that have a very high tax payment system, countries that are paying for health insurance, they don't want to know who is the president or who is the government, because collectively that collective payment binds them to demand for good quality healthcare. And so in this case, we're talking about healthcare services. So what the government is trying to do, and development partners like us are trying to do, is to say, currently less than about the level from the National Demographic Health Survey for 2018, I think less than 10% of Nigerian women, I don't know the number, I can't remember the one for men, are even aware of health insurance as a product that you can use to protect yourself against future stress of health. So what we're doing is to say, how do we support the government, especially with the mandatory health insurance that was put in the revised National Health Insurance Authority Act? How do you get more Nigerians to begin to enroll in the Nigerian health sector? How do we get me and you to begin to pay? Currently, I contribute from my salary health insurance. What that does to me is, any day I go to the hospital, because of the amount I'm contributing, I demand service. And when I'm doing it, I'm bold about it. I'm not, it's not paid by the government. So I'm not jittery about it. I'm not asking half-heartedly. I'm saying I've contributed a significant amount of money for my healthcare, for my family. So I need to get the best of care. So, but to the point about the extent of the package, how wide the package is, most private companies will give you a more comprehensive package than the government does, because like I said, it's an infant stage. So you can't layer on too many diseases on it, right? So the government has come up with something called the Basic Healthcare Provision Package, a benefit package.
What does it cover?
So it covers things like antenatal care, malaria. It covers things like illnesses. For instance, if you have a snake bite, if you have fracture, if your woman is cesarean section, she can have
up to CS.
Yes, up to CS. Yes, up to CS.
What about things like cancer?
Yeah, so for things like cancer, there's some group of CSOs who are advocating and working to see how cancer can be included. For Engender Health, recently we worked with a team with the National Health Insurance Authority to see how fistula can be included into it. Because fistula is one of the common obstetric morbidities for women. Accounting for over 40% of Nigerian obstetric morbidities in Nigeria. So we are working with the Nigerian Insurance Authority to see how we can include fistula as part of the services that women can get surgery for. And even some aspects of family planning are still missing.
Yeah, I was going to ask about that because of
for family planning.
Your organization is centered on
family planning. So we are also part of an advocacy group who are also pushing for family planning. Also HIV and tuberculosis. Those are not yet in the fully covered as we want it to be. Yeah. So, but the point I'm trying to make is that you start with a package.
Yeah.
And it's running and it's evolving. as the pool increases, you keep on layering on several layers. Cancer treatment is expensive.
It is expensive everywhere in the world.
Yeah, so from a management perspective, when before we started, you were talking about business school
and investment.
You don't want to start everything at once. The funds will dry out and the system crashes. So for me, I think two things are happening, or we need to happen. How do we get more Nigerians embracing the health insurance space? It won't be easy at first. You may not get the best of services you want to get, right? And the government, of course, we also need to hold the government to account to make sure that those funds are being used as they are used as well. But I'm just Engender Health. I'm not in a community in maybe Ilaro in Ogun State or in maybe Okene in Kogi State or Eastern. It's the people themselves who need to own it, contribute, and then hold those facilities to account. Because what happens is every month or every quarter, money is sent from the insurance agencies to the primary healthcare centers to improve on their services.
Oh,
yes.
Because I was going to say that a lot of times, first of all, we live in a low trust society.
Very low trust.
We don't trust that if I pay. I mean, I don't even trust that the taxes I pay do you get what I mean? Yeah. So the average Nigerian is thinking, I pay 1,000, 2,000, whatever the amount is every month for health insurance. So there's number one, there is the selfishness, right? I'm only thinking about myself. Oh, how often do I even get sick? I don't want to pay it.
God forbid.
God forbid.
God forbid.
Yeah. There's a lot of, and then there are people who say, I live and die on the altar of God, wake up NSPPD or Pastor Bolaji, everybody's like, my spiritual father, has got me, right? So there's that aspect. Yeah. There's also the aspect of people who don't think they would get good service. I've had a lot of people complain. Yes. You go to government hospitals, you are left in the waiting room for hours and hours. Yeah. And even sometimes when they do attend to you, you're not given the best of services. So sometimes I see that as a reason they would pull back to not want to engage. Even when I said them insurance, they're thinking, I need food to eat. I need Coke and bread. I'm not here to.
Yeah, I think historically, we are not a saving. Historically, we
save, like ourselves.
We save, right? And we love ourselves, right?
No, I mean, we don't like. I don't like you. I like me.
I'm paying.
I like me.
I'm not falling
sick. Exactly. So how do you resolve that? I like your point you write about some of the cultural and religious dimensions to the work we do. And that's why when we work, we have to really engage with the religious leaders, the traditional leaders, to say. I recall when I was practicing, like in the clinic, and I saw a client who came in with a blood pressure of 180 over 110. Now that is like severe for viewers. That's like severe hypertension, with significant risk of stroke and stuff. And all the other antecedent complications as well. And when I started engaging her, I could see she told me she was coming from one of the religious homes who had
mission said, homes.
Yes, who had said she's fine, but she let her come to the hospital and check. So when I told her, I said, "Oh, you have severe hypertension." She said, "No, that they've told her that it's been cured, and that she just wants to come and check." So now you have to be careful, because when it comes to things around religion and culture, those are rooted beliefs. Those are things that people grow up
and you can't fight them on this.
You can't fight them. So you have to, because you have to be focused on your results. The result is you want this woman to be well. So you to whatever biases you may have about her culture, her religion, her literacy level, is how does this woman enjoy the full health that she deserves. And so I told her, I said, okay, that yes, but at least you are here in the hospital, and I completely agree with that. You're okay. It's good. I mean, you need to pray to God for spiritual uplifting. But just like you, I was created by God. God sent me to school. God created knowledge, which I've now learned. And from what I've seen, I think you need to take some drugs for a while, unless to complement the spiritual healing you're experiencing, right? Yeah. So I didn't go around and say, how can you? Because you've mentioned
You have to speak to her in the language she understands.
Yes, but trust. You said something about trust. She doesn't trust me.
Yeah.
She doesn't. She's reading for the first time. She trusts the
clergyman
religious figure who has constantly played a role in her life. So I'm not going to in one day break that trust. If I try to do that, she will never come back to me.
Yeah.
So I don't dismiss that trust, but
So you don't try to make her look foolish.
I don't try to make her look foolish, and I don't dismiss that trust. I try to say, I agree with, I believe with the trust system you have, but also begin to trust me, and let's work together with your trust to make you get better.
Yeah.
So she now begins to me as a partner who respects her religious beliefs, and that means she will come back, and that gives me more time to engage her till the point where she was not fully taking her blood pressure. You know, I look at the average, when we talk about the rate at which people die nowadays, or you're coming back to health as well.
Yeah.
You will find out I know for Nigerian women is a bit higher, but between the ages of, I think, 48 to 56 is where you find most people begin to die. That's like the kind of the age rate. Now, if you look at that age, what does that age say to you? That is the age where people are beginning to come into their elements, career-wise, business-wise.
Yeah.
That's the age where people are, in the next, I don't know if you're 1985, right? but you!
I'm 30 at 1985.
But by the time Bumi is getting to 50, devnow is probably international. Like, it's getting to that stage where it wants to really launch, and you have your support system depending on your family. You understand?
Yeah.
So that is the point where lives have been truncated, and that has a ripple effect on entire families, because the career, the person who is invested in the career, like who is shouldering the body, both the man and the woman, that's when they go, and then you leave children behind who now have to struggle as well. So that's why you need to really take this health issue seriously. Because and I'm trying to link it back to the business side and how it impacts the economy. Because at that point, your business wants to blow.
Yeah.
And then something happens to the CEO, to the founder, to the major driver, and that affects the entire economic system, at least for that house. And then if it's occurring in multiple, when it comes to aggregates, then it has a big impact on the lives of women and children as well. So really something to
okay.
To
so now
about.
Let's go deeper into your success stories.
Yes.
I mean, we've talked about the challenges a lot. Regarding at the policy level, trust issues, and all of that. Let's now look at some of your success stories over time. I know you can't reel out all.
No, definitely.
But there are some that when you want to go to bed at night, you be like,
yes.
Engender health, we tried.
Yeah.
Let's have a couple of them and bring the devnow audience into your world. Yeah. And I know since it's success stories, you can mention local government, you can mention state, you can talk about the program a little bit so that people understand what the program was seeking to address. Probably some of the activities also that led to the success stories.
Yeah. So, I could give several examples. I'll talk, one around fistula.
Okay.
Like I mentioned earlier, fistula.
While you're talking about fistula, I know what fistula is.
Yeah,
she
I know
knows what fistula is.
Exactly.
But please help us break it down.
Yes. So fistula is really an obstetric condition, where fistula basically means a hole. It's in a hole, and it means a hole between two surfaces, and it's a complication that occurs, for women who suffer prolonged obstructed labor. Now, averagely, I would say 7 to 5% of pregnancies will go into complications. Yes,
somebody's freaking out there already.
But the challenge is not really the complications they go into, because we know they'll be going to the complication even in the US, in Nigeria, anywhere. They will go into those complications, even if they have the best of healthcare. A certain number of women will always go into complications for various reasons.
So 5 to 7%.
Yes.
Okay.
So one of the things they go into, one of the complications they go into is obstructed labor, where for various reasons the baby is not able to come through the normal channel of delivery. Through the vagina, the normal channel of delivery. So imagine you have like a balloon, and it's supposed to go out through the exit, but it's obstructed. And pressure builds. What happens? The balloon bursts, right? Yeah. So what happens is that occurs. That prolonged labor will occur in several pregnancies. The challenge is not the challenge is not that it's obstructed. The challenge is it's prolonged, because once it gets prolonged for up to 12 hours, then because there's pressure between the vagina or the uterus and the bladder that is in front, or the anal wall in the back, the friction begins to create a hole between the two of them. So really, really terrible condition with comes a lot of stigma. And so what happens is that, of course, complications, the woman can lose the baby, she can lose her life. But where that occurs and there's a fistula, it means that like I said, the bladder, which stores the urine, it means the urine now begins to go not through the normal channel it goes through, it now begins to come through the vaginal opening. And then because it's at the back, is connected to the face, to the anal wall, it means feces begins to come out through the vaginal opening. So imagine that severe condition, and in Nigeria, based on estimates we have, and it's about 13,000 of those cases, 13,000 of those cases occur every year.
Wait, not in total, just every year?
Every year. We now estimate probably about 150,000 to 200,000 women in Nigeria live with this morbid condition. Now, there is a treatment. And there is a treatment in Nigeria. So in Nigeria, as a response, in government hospitals, so the government in the last 12 years has set up national obstructive fistula centers across the country. You have there are 4 of them in Bauchi, Ebonyi State, in Katsina, and one in Edo. And then you have some states that also have set up those. I know in Sokoto you have them, and Sokoto also have. Now, in those facilities, both the state and federal government have made fistula treatment free.
Okay.
So if a woman who has fistula, she can actually go to the facility for free. But the challenge is the funding to those centers are not enough
to take care of the
burden. Averagely, we are seeing from the district health information system, which is like the portal that houses health information for the country. Averages of 4,000 fistula repairs are being done every year, and I just told you that we are seeing cases of 13,000 every year. So it means on every year we have a deficit of about 9,000 plus women who are not getting access to care. So recognizing this with funding from the USAID in Nigeria, we're implementing a project called the Momentum Safe Surgery and Family Planning Obstetrics Project. Okay. And one of the things we are doing is to build capacity, is to expand capacity of doctors and nurses to be able to treat this condition, because the treatment of choice, especially when it's not captured early, is surgery.
And so I was going to ask, these treatments, can they give you your life back? Would you go back to normal, or there is you'd lose an arm or something? Yeah. So now, just as I described the condition, it means, from what I described earlier, it means that if there was a patient with fistula here sitting there with us, what is one of the things you will first notice?
Should be smelly.
Smell.
Use the smell. So that smell is so recognizable that it turns people off. And that begins to drive stigma and discrimination. You begin to shy away from community, you lose your friends. We have cases where husbands leave their wives.
Yeah, I was going to say,
that. Yes, exactly. Husband leaves their wife, and women are pushed to maybe a part of the community, or
just stay there,
and then have to leave.
You have leprosy.
Yes, exactly. And so that stigma and discrimination means when you look at the economic side of things, that woman cannot go and work in a business. I mean, who will employ her in the business? Because I mean already.
So source
of livelihood is also truncated as well. Even if you had your personal business, how many people will want to patronize you because of this?
Doesn't even matter what you're selling. You can be selling phones.
Exactly, and then you also have all the cultural misconceptions. You know, whether it's some voodoo, witchcraft, or because you know, depending on the culture you are, they link it to maybe something the woman has done, which is now like a punishment on the woman, right? Yeah. Not really knowing that this woman is experiencing this because she's doing one of the most important, if not the most important thing in humanity,
womanhood,
to ensure that humans are able to procreate and continue to survive in the world, to give birth to a life. And it's through this really beautiful process that a woman suddenly experienced this terrible condition, and society, you know, pushes out. So like I mentioned, the government is doing a lot with funding from the US government. We were able to partner with the University of Abuja to see how we can train their they call it urogynecological units. It's like a unit specializing on fistula surgery, so that there are more doctors and nurses able to manage this condition. But for the training of doctors is really practical. And so what we did was to also mobilize women from around Abuja, Kwali. So the woman I want to talk about actually came from Benue State.
Wow.
Through the radio program she heard. She actually came from Benue State. And this woman her age was above 60. She had lived with fistula since she was after she gave birth to her last child, since she was about 25, 27.
Stop.
No.
Yes.
So we're talking 35 years.
So we're talking 35 years of her life going through without access to
more
care.
years being
more years of, you know, than
the years she had
before
lived.
she
had fistula.
She had the condition.
Yeah, it was. In fact, when we did the surgery, because the surgery was free, all the consumables, everything was fully provided by the government through this partnership. We took a couple of other women, but I think her own case for me was really striking because
35 years.
Yes, 35 years. That's like a lifetime. You know, that's like you've lived all your youth. 35 years.
That's like half of Bumi's age.
Half of So yeah, but so she was amazed, and she said that it's hard to believe that she lived with this condition for so long. She didn't have access to information about even to understand what she was going through.
She probably thought it was a spiritual attack or something.
Yes, because, and the funny thing about this, and that's where we need to call into question some of the damage sometimes that is done, culture, religion, because she shared, because when I even looked at the woman, she had, it's not that she didn't have the money to pay for the surgery.
No.
Yes, because
she just didn't know.
She just didn't know where to get the best care.
Oh,
because she
my
had
God.
invested, she had paid severally different traditional homes or different setups for herbs and other things to try and take care of the condition. So access, so just by putting out that information out to the public, the project did to say, describing the condition, to say this condition exists and there are several things you can ask yourself. You know, you understand. Did you start experiencing this after childbirth, right? Do you wet yourself after childbirth? Do you see urine or feces? Did you communicate after childbirth? Once you ask it, go to the hospital to come to present for care. Just 3 simple questions. And by the time you put this out to the public, through a partnership with, we did it through a digital space where it's a calling number where you call in into the, and this one was able to hear and come for this program. And she said that for her, she felt like we had given her back her life. Yes, like she felt for the first time like a woman.
No.
Yeah.
All I can imagine is the opportunities she's lost.
Yeah.
The family and friends she's lost. The confidence in herself that she's lost.
Yeah.
I can't believe that woman spent 35 years of her life, longer than she's been alive.
Yeah.
Prior to
there
that.
are lots of them. I mean, this is just one out of many. This is not like an exception. There are many women who are not having access to care despite the investment. And And just like you talked about, and that's why when you look at fistula program that we are currently doing, in Nigeria, you are pursuing a holistic approach. We're saying beyond the surgery, what are some of the other things these women need? Psychosocial counseling.
Yeah.
Because you've gone through a lot of traumas.
I was going to ask about their mental
state. Yes. So we worked with a local partner, the International Society of Social Workers of Nigeria, based in Lagos, who provide certificates to social workers in country to see how they can build capacity of social workers in Nigeria and across the fistula centers. So those now, when the fistula clients come, now they now have access to a social worker to provide psychosocial counseling to them, screen them, understand what are your needs. And that screening tool we developed also asks several questions, like ask about whether you want access to family planning. You take your nutrition assessment, it's a nutrition assessment to check whether the woman is nutritionally fit. Is looking at issues around gender-based violence, because there are fistula, like I gave you a process around childbirth, but fistula can also be caused by rape. So for forceful rape, all rape is forceful. Saying. Yeah, exactly. So for rape, especially for rape that occurs in younger, maybe children, it can lead to fistula. So we have a gender-based violence component that is also asked whether you experience gender-based violence, and if that needs to be escalated to the one-stop shop, so that where you have the legal units, you have the police units, they can now deal with all those gender-based violence as well. And then we now look at economic empowerment. So what we also did is to map out all CSO partners, businesses who are doing some kind of training, entrepreneurship for women, so that when these women are able to go through the surgery, if you want family planning, you are linked to the family planning clinic to have family planning. If you, of course, all women go through the psychosocial counseling sessions, and then if you have nutrition deficiencies, you have the dietitian who's able to provide support to you, advise you on food to eat and all of that. And then for women who are still within the reproductive age, because if you've had a fistula, when you want to give birth, it's advised for you to give birth once it's been repaired. You can actually still give birth.
I was going to ask, are you able to
reproduce? Yes, you can. Yes, so once the fistula is repaired, you're able to still reproduce. So what we do, but it has to be through cesarean section. So what we also did is to leverage on the government. I mentioned earlier about the government health insurance program, right, which is usually for poor, vulnerable people. If you look at fistula, it also occurs in poor, vulnerable communities, right? Because of access to care and all of that. So what we do is we link with the government to identify or kind of classify, for those who give consent, them as poor and vulnerable, and then allow them to have access to the health insurance scheme. So, and then we partnered with the state health insurance agency across the states. So in Bauchi State, we got 500 slots, so that women with fistula, once you get repaired, you can go to the government, they give you access to an insurance card. When you get pregnant, you can go to the hospital for antenatal care, and then when you are giving birth, you come to the facility for cesarean delivery as well. So in total, is a holistic approach that we are doing in country.
My other question, and to me it's not frivolous, I think it's very important. After the fistula has been repaired, is it possible that the women who were afflicted would be able to have pleasurable sex after going forward?
Yes, so it's possible for them to have pleasurable sex after they go forward. So one of the things we did when we Engender Health was to look at the quality of the surgery. So now, medicine is apprenticeship, right? Like, just like when you take your car to the mechanic, if it's an electrical problem, you don't want the mechanic guy
to be the one
doing it, or the panel beater doing it, right? You want the electrician guy doing
professional.
It, right? And even within that, everybody has a level they can do. Some mechanics, when you see the level of work, you say, I can't do this. Let me call.
Even setting cars.
Even setting cars, right? Setting cars. So it's the same thing with surgery. Everybody has their surgical competency, and so for fistula, the most important thing is for the woman who has a fistula having the first surgery done by a surgeon who is competent to handle that type of fistula, because there are several types of fistula. Just to come back to your point, so where the damage is done extensively to vulva, those tissues, the clitoris around where the vagina is, you need to make sure that that woman has access to a surgeon who's able to provide that's the best surgery for her.
Yeah.
If that doesn't happen, the surgery will fail. And if the surgery fails, it becomes harder the second time.
Yeah.
And it becomes harder the third time. And then if that continues, that gets you to women we have called women deemed incurable. Women who the surgeries, they've had so many surgeries that it's hard to now even repair them. And that exists. You have a lot, you have a significant
And you've
number of
met
them.
a couple.
Yeah, if you, I mean, we can go to Sokoto, go to all these states.
So what is the quality of their lives? People who have tried to.
Yeah, so that's where the quality of their life now becomes a big issue. And what we are now doing is what we did was to develop work with the Federal Ministry of Health to say, how do you work with the surgeons, build their capacity, but also let each level surgeon know their level. If you see once you see the operating space and you identify that this is beyond me, there's nothing wrong with saying,
Let me call for help.
I can't deal with this.
Yeah.
Let me refer you, or let me call the senior surgeon, because the minute you go in and you do it, you make it worse for the women. And so you have surgeons, you have the surgeons in Nigeria. We're not talking about flying outside the country to do
Right
this
here.
surgery. You're right here in Nigeria, in Abuja. You have several surgeons in Ibadan. Most of the teaching hospitals have these surgeons. But how do you make sure that they're able to do the right repairs and give the woman back her full reproductive function? Because when we talk about health, reproductive health, it's not just about giving birth. It's making sure women enjoy the full pleasures of sexual activity, because it is their right to that.
Yeah, I was going
Yeah.
to say, it's
Yeah.
very
It's
important.
it's a right.
Yeah.
You understand, to
Yeah.
experience that as well. Yeah, just to mention that.
Wow.
Hey, a lot, right?
You know when in Yoruba language say "Motiyo,"
What does
like
that mean?
I'm full.
Oh,
I mean, when you hear all of
Yeah,
this
so,
all of this work going on, on the field regarding the success stories, it's definitely a lot. Now, in just a few words, what are some of the things that you wish people knew? Particularly, I won't even delve into other aspects of your work. Let's just stay with the sexual and reproductive health part. Yeah. What are things you wish people knew, especially at the community level? Basic things that you wish they knew. And from your years working in the development space in health, you've seen that, these are reoccurring issues. If these people had this kind of information, probably it won't degenerate to this. Like the case of the woman you mentioned, who had been living with fistula for 35 years. What are a few things?
Yeah, so in health, we talk about the three delays to healthcare. And the first delay is the decision making at the community level.
Yeah.
The decision to go to take action for your health. And then the next delay is decision to move to the health center. So like things like transportation, logistics. And then the third delay is the one you experience in the healthcare center. So you go to the healthcare center, but
They've not attended to you.
All the issues, waiting time, quality of care as well.
Yeah.
So the community level, which is what you're talking about now, is that people need to recognize that health is wealth. And despite the quote unquote the high religiosity or spirituality we have as Nigerians, right? You need to recognize the fact that you need to go to a healthcare facility to seek the right care. I think for me that is one of the biggest
challenges
we have. I don't think me personally as a human being, I embrace religion like with all sincerity. I love religion as well. But I also believe that when I'm sick, and I also believe I will be sick
at some point.
At some point, there's no.
It may just be headache.
But I know if somebody will say, "Oh, by the grace of God, you'll never be sick," I'm like, nah, that's not happening, right? I know I will be sick. So it means that the decision to be able to recognize that I'm sick and go to the hospital to access care. We're talking about reproductive health. If adolescent girls, requires protection, to prevent against STIs, against HIV, she should be able to go and enjoy the full privacy and confidentiality of to access services as well. So for me, I think it's to say that it doesn't degrade your faith.
Your faith.
It doesn't degrade your faith for you to go to the hospital or for you to access care from the right place. And you need to, in the area of internet, if you have access to phones, I mean, people check internet, but go to a hospital and seek care. You understand? If there's any issue, seek care early, because sometimes the earlier you seek care, the better it is. Most of the reasons we have mortalities, you check most of the general hospitals, they say, oh, they are burial, they are like places where people go to die, is because people have, of the first delay, people have delayed.
They didn't take a decision in time to go to the health facility.
You have a woman who is obstructed at home, being attended to at home. She didn't go to the hospital to deliver, which by itself is an issue. But you clearly see she's bleeding. But that decision to quickly take the woman to the hospital and seek care, I think that's where my biggest issue call will be. Please go to the health facilities. Go and seek care, right? The impact it can have on your life, you understand, and how it can negatively affect your growth career-wise. Eventually, you can't. It's really, really high. And so I think my message really to the community is to say, seek healthcare. You understand?
Seek healthcare. Okay, so 2 things came out from that, and then we'll wrap it up.
Okay.
One is the seeking healthcare part. From statistics, we realize, and please correct me if I'm wrong, because you're the expert in this space. But I realize that one of the reasons why a lot of people don't take that decision in time is economic.
Economic, I agree.
What would you want to see done differently to mitigate that? Since we know that many a times they want to go to the health facility, so when I get there, how am I going to pay?
So and that's where everybody has to work together. So the government, based on the current government's health agenda, they recognize that there are about 80 million Nigerians who are poor and vulnerable and should not or cannot pay for healthcare. So they are currently at about 10 million plus and working to get to 80 million.
To 80 million.
I mean, that's the government's priority. How it's going to be done, I mean, I'm sure they have their plans, right? So, but what happens to the other 120 million Nigerians that are not going to be covered, assuming we are 200 million?
Yeah.
So how do you get these 200 million people to prioritize, 120 million to prioritize health? How do you get them to save on a daily basis towards health? Those who can, right? Who can save? And how do you begin to increase, because health is not just about medical, like I mentioned, it's social. It's you look at it from an economic point of view. If you begin to push more people into from the agri sector into the service sector, into the manufacturing sector, into having jobs, and with the mandatory health insurance, you are getting employers to push for health insurance for their workers, right? You understand? It means more people will be pulling into the system. As there's more people pulling, then you have saved money ahead of time to be able to access healthcare. You know, people say the economic situation is not good. I mean, it's undergoing several turns in Nigeria now. But if you take the Okada riders, for instance, now they earn money, they contribute every week. They have the Ajo where they contribute. People with those books contributing. How do you engage them to begin to invest,
plow some of it
into their healthcare, so that when the decision comes, when you are sick, that economic barrier you talked about is no longer there. And he raised an important point. I always give this story of and how we need to involve more men, because when in Bauchi, we had a small session with men and with women, and we asked them, we took them into separate groups, same question, but separate groups. They to discuss, and he said, if you got a phone call that your child was sick, what would be your first reaction? What's the first thing that comes to your mind? Women group, men group, and come together as a group, discuss and bring out the most important one, because there are several things that come to your mind. What's the most important? So then they came back to report back, and the women said that immediately they hear the phone call, the most important thing is, how do I rush my child to get the best health care I can afford? That comes to my mind. How do I just go to the hospital? you know. And then we asked the men,
Hey.
and the men said, the first thing that came to their mind is, how much will it cost if we go to hospital? How much will it cost if we go to chemist? How much, you know, all those analyses are coming into play. So what that means is that we need to engage men, but we also need to empower women.
Yeah.
As well. So we need to engage men so that they understand the importance of healthcare. We need to engage men so that they commit and invest in healthcare. But we also need to empower women so that they are also able to, when the child is sick, to support. And they not also even lead. You know, your child is sick, you don't have to call your partner to say, oh, this thing. Oh, you inform, and then you are going to the hospital because you know, together or by yourself, you can make that provision as well. So I think for me, that's one important thing that we need to do. We need to get more people to pay for insurance. Health it typically has been seen as a social good, but I think with the current dispensation, we're beginning to see it's more like an economic good, and that's why I was trying to link it to how it affects your investments, how it affects your career, how it can derail the whole economic shape of a family when you lose a mother or a father who has not enjoyed good quality health, who experiences sudden heart failure, does not have access to care and dies. It has a ripple effect on not just the health of those children, their education, their livelihoods. The economic impact is socioeconomic impact is really wide. And so I think for me we need to prioritize health. We need to stop saying people don't. I know people don't have, not everybody has, but for us that have, how do we even prioritize? Because there are millions of Nigerians who can afford 12,000 naira every year to enroll for health insurance. Maybe it's go to a joint and enjoy yourself. Maybe after the show, just go to one joint, then maybe we take us.
But are there certain policies? I'll try. But are there certain policies in place that would make it compulsory for this for health insurance?
Yeah. So just before the former President Buhari left, he signed the revised National Health Insurance Authority Act, which made it healthcare insurance mandatory for everyone. Right. So it means that now in Nigeria, based on the current law, everyone that can afford it should, if you are not on the government's poor and vulnerable program, basic health care provision fund, you should be subscribed to health insurance either at the state level or at the federal level. Of course, like every law or policy that is passed, it takes 3 to 5 years
for implementation.
And it's not just a Nigerian thing. Some are immediate. Like, I mean, when fuel was the policy around fuel. Yeah.
I mean, that was
overnight, man.
Yes, but for some of those developmental issues and policies, yes, those developmental policy issues don't take a bit of time. And so we know that the government is currently working to put in place the mechanisms to ensure that people get on board. But I think they are also trying to see how states can also begin to enroll their civil servants. Most states have enrolled actually, but some are still behind. And then the government latches on its own poor and vulnerable program, which means you have 2 layers now. And then the informal sector is now beginning to take shape across the states, which is pulling in those people who can afford to pay but are not on the system. And the idea is that when you talked about trust and you talked about quality, if they can get the government civil servants into the system, it pulls money. You get the government poor and vulnerable program, it pulls money. Then by then it's strengthening the healthcare services so that when the informal sector people come in, like maybe the Okada riders, the market women, there's some improved coverage and quality of service, so it doesn't discourage them, from pulling back as well.
Man,
so it's a lot.
It's a lot to take in.
There's just lots of layers. While you're trying to fix one thing, you realize that these other aspects we need to capture it also as a component.
I think the whole point is that it would take a group effort to solve these problems. Like, I feel like every health should be centered around every agency and every ministry, because at the end of the day, if health is wealth, health should be our priority. If we're not alive, we can't do anything. So
Wow.
Multi-sectoral approach.
It is. Yes.
Thanks. I agree with you completely. Yeah.
Welcome. Vote for me.
I want to say
Vote for me when I run.
Senator Ugonna Uwajumogu.
You know it.
I love the tweet again one more time.
Senator Ugonna Uwajumogu.
Like my daddy.
Wow. Well, what we can say again is for Engender Health and every other development partner that is working in the health space is to keep up the good work, because
And keep supporting.
because what they do is a lot. I mean, look at when he was describing the fistula thing. Sorry, I know that gives you the creeps. I'll tell the editor not to put anything. I mean, anything creepy there. Not to put anything creepy there. If Ugonna is already freaking out here, they put anything creepy. They just run away from our video. you know. So, I mean, you talked about the surgery, the mental health part of it. I mean, how do you get a woman who has lived with something for that long, been stigmatized, to now be reintegrated back into the system? You also talked about the economic part of it. I mean, if you're not in that space, you probably won't even
think those layers.
Think of those layers. You just say, okay, she has done the surgery, thank you, bye-bye. And then now looking at the aspect of the ones that they've done the surgery over and over and wow. Thank you so much, Dr. Kabiru, for coming through today on devnow.
Thank you for what you do.
Thank you for all you do. And the work of Engender Health is possible through these partners. You can see their logos on the screen. Maybe you can go on their page and give them a thumbs up.
You know what to do.
If your logo is not there, it's Dr. Kabiru's fault. All right. So I want to say also a big thank you on behalf of Engender Health to all of their partners, all of their funders. Thank you so much for what you are doing. And of course, we'll be back again with another episode of DevNow in no distant time. Look at our pages, follow us, like, subscribe. That's the least you can do for us. Share the videos, you know, and then of course you can also recommend to us. You know, we're not all knowing.
Write to us. Let us know.
We're not all knowing. We don't know all of the development agencies. That's also one of the things that DevNow will do in the future. Try to see how we can keep bringing development agencies together, not just in silos. I love the health space. I'm not saying they don't do that in other spaces, but because I think I've studied out of the health a lot, I see that they work more in a community fashion. You know, this particular development agency tells you, oh, this aspect that we're doing, so other people are doing this other aspect, so other ones are doing this other aspect, so other aspect doing this aspect, you know, and they're able to talk about it, you know. So want to say, let's not work in silos, you know, let's come together. I asked someone in development that how many development agencies are in Nigeria, and said nobody knows. Only CAC knows. Only CAC, that's the Corporate Affairs Commission. Said only CAC knows, and it shouldn't be, you know.
And
so
I think a lot of CSOs and NGOs, some of them have a bad rep due to community ignorance. A lot of people think, oh, like you say, they just wear good suits, wear nice watches, get paid fat salaries, and to take pictures of vulnerable people and then posting it. But honestly, there are a lot of CSOs and NGOs like Engender Health who actually do the work. They actually go out there into the field and they actually do this work, and a lot of lives are better for it. So in essence, thank you so much for just existing, just doing what you do. I know it's such a sacrifice, and honestly, like we told Shay, your reward is in heaven. And maybe I don't know. Maybe God will bless you with a good wife and good children that will not embarrass you. Maybe the other ways.
Thank you very much again, Dr. Kabiru.
So
thank you, Engender Health. Catch you on the next one.